Hello everybody and welcome to our module on gastrointestinal pharmacology. Let's start by discussing the antacids. These are all drugs that lower the acid content in the stomach. They're not used that much in the modern era, but years ago, before we had histamine blockers and proton pump inhibitors, these were taken by people frequently when they had symptoms of heartburn or stomach ulcers. Nowadays, people often take them as over-the-counter therapy, which means therapy that does not require a doctor's prescription, and people often take them for occasional heartburn symptoms. There are 4 different antacids: sodium bicarbonate, calcium carbonate, aluminum hydroxide, magnesium hydroxide. We'll talk about all 4 in the next few slides. First, we'll talk about sodium bicarbonate, which you may know by its other name, Alka-Seltzer. This is its chemical structure shown at the top of the screen here. And it's helpful to understand the chemical reaction of these antacids so that you can understand some of their systemic effects. So the chemical structure of sodium bicarbonate is NaHCO3 as shown on the screen here, and it reacts with hydrochloric acid in the stomach to form sodium chloride and water and carbon dioxide. And carbon dioxide, as you may know, can go on to form bicarbonate if it mixes with water. So once you understand this equation, it's easier to understand some of the potential side effects of sodium bicarbonate. All this CO2 can produce gas and bloating, so people who take Alka-Seltzer often have bloating and belching from the carbon dioxide. In addition, the CO2 can go on to be absorbed and form bicarbonate, so potentially if you took a lot of sodium bicarbonate, you could develop an alkalosis from all the bicarb absorption. And then finally, sodium chloride is formed from sodium bicarbonate, so potentially if you took lots of Alka-Seltzer, you could start to retain fluid, and if you had heart failure, you could get symptoms of fluid retention, and all that is from the sodium chloride reabsorption. The next antacid is calcium carbonate, which you may know by one of its trade names, which is Tums. This is the chemical structure of calcium carbonate on the screen here. It reacts with hydrochloric acid to form calcium chloride and water and carbon dioxide. So once again, just like with sodium bicarbonate, you can get bloating and belching from the carbon dioxide that's formed in the stomach. You can also potentially get an alkalosis if that carbon dioxide is absorbed and converted into bicarb. An additional side effect of calcium carbonate is constipation. Electrolytes have variable effects on smooth muscle function in the GI tract, and calcium slows down smooth muscle function, so it tends to slow movement of substances through the GI tract, and that can lead to constipation. You can just remember that calcium decreases GI motor activity. We'll talk about how some other electrolytes affect GI motility in the subsequent slides in this module. Because calcium is part of calcium carbonate, you can potentially absorb the calcium and get hypercalcemia. You have to take a lot of calcium carbonate for this to happen. And this ties into a special use of calcium carbonate other than as an antacid, and that is in the treatment of hypocalcemia. Patients who have hypocalcemia are sometimes administered Tums to try and raise the calcium level. Calcium carbonate has 2 special potential adverse events that you should be aware of. The first one is called the milk alkali syndrome. This is more of a historical syndrome. You won't see this very often in the modern era, but years ago, when we did not have good treatment for gastrointestinal ulcers, patients would drink lots of milk and consume lots of calcium carbonate or other antacids for the treatment of their ulcer symptoms. This sometimes led to something called the milk alkali syndrome. This was a triad of hypercalcemia, metabolic alkalosis, and renal failure. The hypercalcemia came from drinking milk or from taking calcium carbonate. The metabolic alkalosis came for 2 reasons. First of all, carbon dioxide is produced, as we saw on the last slide, from calcium carbonate, and that can contribute to a metabolic alkalosis. In addition, hypercalcemia promotes urinary flow, so these patients would get dehydrated and they could develop a contraction metabolic alkalosis. And then finally, the renal failure mechanism is poorly understood, but it's due, at least in part, to the polyuria produced by hypercalcemia and dehydration. Another potential adverse event of calcium carbonate is what's known as acid rebound. This is a mild acid surge once the antacid washes out of the stomach. The probable mechanism is stimulation of acid secretion by calcium, and this can happen with other antacids as well. It's mostly detected in studies where they do stomach pH monitoring before and after patients take these antacids. The clinical effects of this acid surge are questionable, but potentially a patient could have their symptoms ramp up once the antacid leaves the stomach for this reason, acid rebound. Our next antacid is aluminum hydroxide. This is the chemical structure of aluminum hydroxide shown at the top of the screen. At the bottom is its chemical reaction with hydrochloric acid. It forms aluminum chloride and water. It does not form carbon dioxide, so it won't have bloating or alkalosis like we saw with the last 2 antacids. What it can cause is constipation, and that's because, much like calcium, aluminum decreases GI motor activity. In addition, aluminum is a well-known binder of phosphate in the gut. It forms aluminum phosphate complexes, And this can potentially cause hypophosphatemia, which generally presents as muscle weakness. You would have to take a lot of aluminum hydroxide for this to happen. But in addition, it creates a role for aluminum hydroxide in renal failure patients. Renal failure patients often suffer from high phosphate levels and hyperphosphatemia, so they can be administered aluminum hydroxide as a so-called phosphate binder in order to lower the phosphate levels in the serum. Other than hypophosphatemia, the one other potential side effect of aluminum hydroxide is aluminum toxicity. This is very rare except in renal failure patients who cannot excrete the aluminum. It usually occurs in dialysis patients who are taking aluminum hydroxide as a phosphate binder. The symptoms of aluminum toxicity include bone and muscle symptoms. These patients can develop bone pain and muscle weakness, and they can develop a softening of the bones called osteomalacia. In addition, there is a microcytic anemia that is characteristic of aluminum toxicity. This is because of accumulation of aluminum in the bone marrow. This will look like an iron-deficient microcytic anemia. However, there are normal iron studies, and if you administer iron, there is no benefit. Sometimes this is described as a microcytic anemia that is resistant to iron. And then finally, patients with aluminum toxicity can potentially develop dementia. The final antacid we'll discuss is magnesium hydroxide. Its chemical formula is MgOH2, so it reacts with hydrochloric acid to form magnesium chloride in water. There's no carbon dioxide formed, so there's no bloating or alkalosis with this antacid. Its major side effect is diarrhea. It's poorly absorbed, so when it gets to the colon, it functions as an osmotic agent and draws water into the colon, and this can create an osmotic diarrhea. This creates an alternative use other than an antacid for magnesium hydroxide, and that is as an osmotic laxative. You may have heard of milk of magnesia. This will draw fluid into the colon, promote peristalsis, and help patients to move their bowels when they have constipation. Another potential side effect if you took a very large amount of magnesium hydroxide is that you could develop hypermagnesemia. The symptoms of hypermagnesemia include hypotension, bradycardia, and potentially a cardiac arrest. You may have heard of Maalox. This is an antacid that is a mixture of both magnesium and aluminum hydroxide, and the reason magnesium and aluminum are mixed is because their diarrhea and constipation effects will offset one another. So whereas the aluminum will tend to bind patients up, the magnesium will tend to promote bowel movements, and as a result there is hopefully and usually not much effect in terms of constipation or diarrhea, but patients do get the benefit of the acid suppression. The absorption of medications can be altered by all of these antacids, and that's because the drug can bind the antacid. In addition, the increased gastric pH affects the absorption of some drugs. Some of the most important drugs that are at risk for poor absorption in the setting of antacids include tetracycline, also fluoroquinolones, isoniazid, which is a tuberculosis drug, and iron supplements. Tetracycline is notorious for being influenced by the level of acid in the stomach in terms of its absorption. This picture shows the chemical structure of a tetracycline molecule, and I just want to show you that aluminum and calcium and magnesium from antacids can bind two tetracycline molecules together, and once they're bound like this, they don't get absorbed. So this is why taking tetracycline in the setting of some of these antacids can lead to poor absorption. Now let's talk about the histamine H2 receptor blocker drugs. These include drugs like famotidine and ranitidine and nizatidine and cimetidine. And it's hard to emphasize what a breakthrough these drugs were when they first came out. Prior to the development of this class of drugs, many patients had chronic stomach ulcer symptoms. They often had perforated ulcers. Surgery was done for ulcers. These drugs really represented a medical breakthrough. Nowadays, you almost rarely see severe ulcer symptoms. All of these drugs block histamine receptors in the parietal cells. I talk about this in more detail in the GI physiology modules. Most of them have relatively few side effects and are very well tolerated, and many of them are now over-the-counter and can be purchased without a prescription. A major side effect among the elderly is confusion. These drugs can potentially block some histamine receptors in the central nervous system. The elderly are particularly vulnerable to this and may become confused on these drugs. In addition, these drugs are metabolized in the liver, so rarely they can elevate the AST or ALT levels. And in some patients, there have been some reports of cardiac arrhythmias. This is very rare, but this has to do with blocking receptors in the heart. Cimetidine is really unique among the H2 blockers. It was the first H2 blocker on the market, and it's rarely used in the modern era because it has a number of side effects that are not seen with the other histamine blockers. One of its unique side effects is that it's a potent P450 enzyme system inhibitor. In addition, it's an anti-androgen, so it can cause gynecomastia or impotence. It can even sometimes cause prolactin release. It more easily crosses the blood-brain barrier and affects histamine receptors in the central nervous system, so patients on cimetidine can develop dizziness and confusion and headaches. And then finally, it's very unique in that it reduces creatinine excretion in the kidneys, so the serum creatinine level will rise, But this is not because the patient is developing renal failure. This is merely because cimetidine is blocking the excretion of creatinine in the urine. And years ago, when this was the only drug available, you had to use cimetidine for people with ulcers, and you would have to deal with all these side effects. Nowadays, we really just pick one of the other histamine blockers, so we don't have to worry about all the things on this slide. Now let's talk about a class of drugs called proton pump inhibitors. And in the modern era, these are really the major class of drugs used to suppress acid production in the stomach. These include drugs like omeprazole, pantoprazole, lansoprazole, and esomeprazole. And all of these inhibit the hydrogen-potassium pump in the parietal cells, and I talk about this in more detail in the GI physiology modules. In general, these drugs are very well tolerated and have few side effects, especially if they're only taken for a little while. There have always been concerns about what might happen if you take these for years and years, because potentially the suppression of acid over the long term may cause side effects. Among patients taking proton pump inhibitors for long periods of time, there have been increased rates of C. difficile colitis and pneumonia noted. The C. difficile colitis is believed to be due to loss of protection from gastric acid. It's believed that the gastric acid prevents the bacteria from invading and colonizing the GI tract. The increased rates of pneumonia have believed to be due to more pathogens in the upper GI tract. Again, because you have less acid there, there's less protection against these pathogens, so they are able to colonize the stomach, and potentially this could lead to pneumonia. Other than increased rates of infection, the other concern with long-term administration of proton pump inhibitors is malabsorption. Malabsorption of various substances has been reported in patients who are taking these drugs for long periods of time. This includes hypomagnesemia and low calcium absorption, which can lead to hip fractures, especially in the elderly. There have been reports of B12 deficiency. You may know that you need intrinsic factor to absorb B12, but you first need acid in the stomach so that B12 can be separated from dietary proteins. This is less likely to occur when there's less stomach acid around because of proton pump inhibition. In addition, patients have been reported to absorb less iron and vitamin C when they are on long-term administration of proton pump inhibitors. The next drug we'll talk about is bismuth salicylate, which you may know by two of its trade names, Pepto-Bismol or kaopectate. One use of this drug is to treat abdominal pain related to ulcers and erosions, and that's because it coats ulcers and erosions in the mucosa and protects them from acid exposure. It turns out it's most effective in ulcers caused by H. pylori, so as we'll talk about in a minute, at least some of the benefit of this drug is due to antimicrobial effects on H. pylori. Now, another portion of this drug besides bismuth is the salicylate portion, and that portion inhibits prostaglandins. And this is helpful in diarrheal illnesses because it turns out prostaglandins stimulate the release of mucus and water in the GI tract. So by inhibiting prostaglandins with salicylate, you will reduce stool frequency. So a second use of Pepto-Bismol, as you may know, is in diarrheal illnesses. One special effect of this drug is that in the colon, the bismuth reacts with hydrogen sulfide and forms bismuth sulfide. This will blacken the stools. So people who are taking this drug will notice jet black stools. This can sometimes be confused with melena from GI bleeding. And when someone is suspected of having melena, one of the first things you have to do is ask if they've recently taken Pepto-Bismol. Now, as I mentioned before, this drug has been shown to have some antimicrobial effect on H. pylori, and for that reason, it's sometimes used as part of so-called quadruple therapy. Usually the treatment for H. pylori is triple therapy with a proton pump inhibitor, one antibiotic like clarithromycin, and a second antibiotic like either amoxicillin or metronidazole. Sometimes tetracycline is substituted for one of these antibiotics, and that's triple therapy, these three items at the top of this list. But sometimes a fourth agent is added, that's called bismuth sulfate, and that's called quadruple therapy, and that's used in regions where there is a high rate of resistance to some of these antibiotics. And the reason it's used is because there is antimicrobial activity of bismuth salicylate. Sucralfate is a drug that contains two components. One component is a sulfated polysaccharide. The other component is aluminum hydroxide, which is the antacid we discussed earlier. Much like Pepto-Bismol, this drug binds to ulcers. There are negatively charged portions of the sulfated polysaccharide drug molecule, and they bind to positively charged portions of the ulcer. This protects the ulcer from acid, and it can lead to ulcer healing. Adverse effects are relatively rare because the drug is not absorbed. Potentially, you could develop aluminum toxicity from this drug because it contains aluminum hydroxide. Next, we're going to talk about a number of drugs which are called osmotic laxatives. All of these drugs are not absorbed, so they function as an osmotic agent and they draw water into the intestines. This stretches the intestines and results in reflexive movement of smooth muscle, and this leads to bowel movements. They can all be used in constipation, that's why they're called laxatives. These are also frequently used for bowel prep for colonoscopy. Before you can have a colonoscopy, You need to completely clean out your colon, so often large dosages of osmotic laxatives are administered. All of them carry the same side effect profile, which includes dehydration. They can cause you to lose so much water in your intestines that you can become dehydrated. In addition, all those fluid shifts can draw electrolytes out in the stool, and this can lead to electrolyte abnormalities. So one of these we've already talked about, that's magnesium hydroxide, which you may know as milk of magnesia. Magnesium citrate is magnesium plus citric acid. This also functions as an osmotic laxative. Polyethylene glycol is a synthetic polymer. You may know it by the names Miralax or Go Lightly. You mix this with water and then drink it, and it produces a large volume of bowel movements. Sodium polystyrene sulfonate is sold under the trade name Kayexalate. This is a polymer. It's called a cation exchange resin. One thing it does is function as an osmotic laxative, so it will produce a bowel movement. But in addition, it binds potassium in the gut, and therefore it's got a role in the treatment of hyperkalemia. Patients who have high potassium levels in the hospital that don't require emergent therapy with dialysis or insulin or glucose or any of the other emergent treatments for hyperkalemia will often be administered Kayexalate. Over the next 24 hours or so, they will have several bowel movements, and that will lower the potassium level. Sorbitol is a sugar alcohol which functions as an osmotic laxative, and sodium phosphate is also an osmotic laxative. The final osmotic laxative I'll discuss is lactulose. Lactulose is a synthetic disaccharide. It's osmotically active, so it functions as an osmotic laxative just like all the drugs I've been talking about on the last two slides. Lactulose, however, has a special role, and that is in the treatment of hyperammonemia in patients who have liver failure. In the colon, lactulose is broken down by bacteria into fatty acids, and fatty acids are acids. That's why they have the word acid in their name, so they will lower the colonic pH slightly. This will favor the formation of the NH4 plus form of ammonia over NH3, and the NH4 plus form is not absorbed in the colon, so it becomes trapped in the colon and goes out with the stool. As a result, if you take lactulose, this will slowly over time lower the plasma ammonium concentration. And this is helpful, as I said before, in patients with liver failure and cirrhosis who are suffering from high levels of ammonia in the serum. Some other milder laxatives which you will use routinely among elderly patients with mild constipation include bisacodyl and Senna. Bisacodyl is sold by the trade name Dulcolax, and Senna is called Senocot. These are called stimulant laxatives. Their mechanism is poorly understood, but they both result in increased GI motility and can be used for mild constipation. And finally, Docosate is a stool softener. It makes stool soft and slippery. This helps elderly patients who have hard stools to pass the stool and have a bowel movement. Rarely you will meet patients who abuse laxatives. These are sometimes patients who have what's called factitious diarrhea. These are patients seeking secondary gain from an illness, so they take laxatives to cause diarrhea. You will also sometimes encounter this in patients who have bulimia and who are trying to lose weight. The clues to laxative abuse include diarrhea and dehydration. You may also see hypokalemia, and you may also see metabolic acidosis from the loss of bicarb. All of these are things you can also see with diarrheal illnesses, but you should suspect it if you have someone with no obvious cause for diarrheal illness who has a reason to potentially be abusing laxatives. Ondansetron is a drug used to treat vomiting. It's called an antiemetic. It blocks a specific subtype of serotonin receptors called the 5-HT3 receptor. Serotonin's formal name is 5-hydroxytryptamine, so 5-HT3 is the serotonin subtype 3 receptor. And these receptors are found in the vomiting center in the medulla. They're also found in the vagal and spinal nerves to the GI tract, so if you block these receptors, you can decrease vomiting. One of the main places where you'll commonly see these drugs used are in patients receiving chemotherapy. Vomiting secondary to chemotherapy is a major problem in the treatment of cancer, and ondansetron really represents a breakthrough. It significantly relieves the side effect of vomiting. In general, this drug is very well tolerated and has few side effects, but some patients experience a headache and some patients develop constipation, and this is all a side effect of blocking the effects of serotonin. Metoclopramide goes by the trade name Regland. It is a blocker of dopamine D2 receptors. In the gastrointestinal tract, dopamine blocks the effects of acetylcholine, and remember, acetylcholine is pro-motility. So dopamine blocks that and shuts down motility. If you block dopamine via D2, then you will have increased motility. Acetylcholine will be free to exert its effects, and this will result in increased esophagus and gastric motility. There's usually no effect on the small intestine or colon. The effects are largely in the stomach and esophagus. That creates a role for this drug in the treatment of gastroparesis, especially diabetics who have gastroparesis from autonomic dysfunction. By blocking dopamine receptors, you increase motility in their stomach. In the central nervous system, dopamine via the D2 receptor activates the chemoreceptor trigger zone. This is found in the area postrema in the medulla, and this leads to nausea and vomiting. So if you block this D2 receptor, you will have decreased nausea and vomiting, and therefore metoclopramide has a use as an antiemetic. It's also very effective in migraines. Many migraine patients, as you may know, suffer from nausea and vomiting, and administration of metoclopramide can be very helpful. A common side effect of metoclopramide is drowsiness. When you treat patients in the emergency room with severe migraine headache symptoms with metoclopramide, they will often fall asleep and then wake up sometime later, hopefully feeling better from their migraine headache. And then you should always remember that anytime you block dopamine receptors, you can potentially cause symptoms that are similar to Parkinson's disease. Parkinson's disease is caused by loss of dopamine in the central nervous system, so when you block dopamine, you can potentially create some of the same symptoms. These are called extrapyramidal movement symptoms. They're also called Parkinsonian movements, and these can all occur as side effects of metoclopramide. This includes a feeling of restlessness, akathisia, which is constant motion of the body, dystonia, which are muscle spasms, and then finally, if you take metoclopramide for a long period of time, the feared side effect is tardive dyskinesia. The word tardive means late. It has the same root as the word tardy, which you may know means late, like being tardy to school. So tardive dyskinesia is a late movement disorder where patients get a repetitive motion like a tic, often of the face, and this is permanent and won't go away, and this is the feared consequence of long-term administration of dopamine-blocking drugs like metoclopramide. Other potential adverse effects of metoclopramide are nausea and diarrhea. This is easy to remember because, like I told you before, it stimulates GI motility. In addition, metoclopramide lowers the seizure threshold, so it should not be used in anyone who's got a history of seizures or epilepsy. And then finally, it can elevate the prolactin levels because you may know dopamine inhibits prolactin release, so when you block dopamine, prolactin levels may rise. This could potentially cause galactorrhea, gynecomastia, impotence, or menstrual disorders. So classic board questions are to ask you certain patients in whom metoclopramide might be contraindicated, and that's easy to answer if you remember what I told you on the last couple slides. Never give it to anyone with a known seizure disorder. Don't give it to anyone with Parkinson's disease because you're only going to make it worse by blocking what little dopamine the patient has left. And then finally, you would never give this to anyone with a bowel obstruction because you're going to stimulate gastric motility, and this patient has an obstruction to movement through the GI tract. And that concludes our module on GI pharmacology.